Jain. And I also thank Vinod and Office of Global Engagement for giving us this opportunity to have a 4-day workshop on innovative primary healthcare for sustainable development. I also thank AARDO for being a great collaborator and a supporter of these initiatives, especially between Asian, African nations, and for rural development, sustainable, equitable, and inclusive development. So Siddhi is actually self-reliant India discussions and debates for humane innovations. This is the acronym. Siddhi is the acronym for the whatever I described just now. And Siddhi was initially conceived as a few webinar series on technology and rural development on the anniversary, on 150th birth anniversary of Mahatma Gandhi. And then adopts of global engagement, and also broadly in the institute, there was a discussion to expand the scope of Siddhi to include technology and sustainable development, technology and equitable development, technology and inclusive development. So because of expanding the scope of Siddhi, we were able to collaborate with AARDO last year during March 2021. We had a 8-day workshop on technology and rural development, especially with emphasis on agriculture, water, resources, environment, and sustainability. And this year, AARDO and IIT Madras is collaborating to hold a webinar series on healthcare, primary healthcare. And the past 3 days, as Vinod mentioned, has been excellent, and the quality of discussion, quality of participation has been really top class. So as today also, we expect the talk to be of great use to both Asian and African nations. And at Siddhi, Office of Global Engagement, we are happy to be part of this collaborative endeavor, which will benefit many countries in the world. Thank you very much. Over to Vinod. Thank you.
Thank you, Dr. Sudarshan. Okay, now we welcome the moderator for today's session. It would be a great honor for me to introduce Professor V.R. Muralidharan, our event coordinator and moderator of today's program. Professor Muralidharan is from the Department of Humanities and Social Sciences in IIT Madras. He is an eminent health policy expert and health economist. He is a class of 1984 Institute Chair Professor, and he is the professor in charge of the Center for Technology and Policy, IIT Madras. In the past, he served as head Center for Sustainable Development, IIT Madras. In addition to that, he served as professor in charge for Lemelson Recognition and Mentoring Program from 2004 to 2006. It's my pleasure to welcome you to this session, Professor. Now, may I request Professor V.R. Muralidharan to introduce the speaker and theme for the day. Professor Muralidharan, over to you.
Thank you. Thank you. And on behalf of IIT Madras and on behalf of AARDO, and on behalf of all the participants here, I would like to welcome you to this webinar series. I request the participants to mute their audio, please. I request the participants to mute your audio. Yeah. So, welcome to the 4th day and the final session of the 4-day webinar series on innovative practices in primary healthcare towards sustainable development goals. In all the primary objectives, I mean, I think we have several times reiterated, and but it cannot be overemphasized. Needs to be constantly kept in mind. Ask the questions, various ways in which people working in different countries, in different contexts, how can they strengthen the primary healthcare system? So in the past 3 days, we have heard presentations on the journey that Tamil Nadu has had in the last 50, 60 years. And we've also heard from the experience of deploying diagnostics and telemedicine from the experience in Rajasthan, the context of Rajasthan, and particularly in addressing urban poor. And yesterday, in fact, we saw the vast data sources that we have, considering the emphasis on evidence-based policy making. What kind of data do we need? What kind of data we have? What are the quality issues we have respect to those data? Despite the quality issues, but we need to move on. How do we use them? These are the various issues we have covered. What our friends from Africa can get from these presentations, including today's, depends on their own context and their own experience and the lens they are using in following and understanding the case studies we are making. Today, you will hear from our friend and colleague, Dr. Yogesh, their experience in reaching out to the unreached, the poor in the state of Chhattisgarh. Yogesh had a master's degree in pediatrics, and he's a public health physician in practice. He has been primarily involved in primary health care through running community health programs in central India. He's a founder of Jan Swasthya Sahyog, which in English means People's Health Support Group at Bilaspur in Chhattisgarh state. He's been involved in understanding technical and political issues through clinical care, observational research and training. Besides, he's also been an advisor to Chhattisgarh state health sector, and he plays a key role in several Government of India initiatives and committees as well. With this brief background to the team and Yogesh, Dr. Yogesh, I now welcome you to this webinar, and over to you, Dr. Yogesh. Thank you.
Thank you, Dr. Muralidharan, for such a glowing introduction. And if I may say, to bond with the friends from both in Asian countries as well as in Africa, I would define myself still as a person, as a physician who's working in a public space, though not in the state sector, not in the government sector. And I'm at the moment speaking from a very remote village in my own state of Chhattisgarh, where the roads have not reached this place, but the network is at least good enough for us to speak together. And I'm going to talk about what innovative measures or what can be done actually to look at the health problems of the most marginalized amidst us in our countries, which are actually very unequal countries, if I may say. So, so I would say here, actually, if I'm going to talk about, whether if equity and justice mattered, then how actually people who are the most marginalized should get their health care. And I'm going to talk about the lived experience of last 20 odd years in one of the poorest parts of the world. I would say this would compete with most poor places, even in sub-Saharan Africa, where I work at the moment. And thus, I would have something to share with, with my colleagues from African countries, even in sub-Saharan Africa. So if I may say, Chhattisgarh is the state which is like a seahorse in the middle of the country. And if you know, India, which is an unequal country, is poor in the center and in the eastern part of India. The West and South India are relatively better off. And so to some extent, North India also. So we work somewhere in the middle of the state of Chhattisgarh in Bilaspur district, as well as surrounding districts, where the defining things about communities are that there is inaccessibility. So this is a woman being brought across a river in Spate, river to for a delivery process, as well as and vehicles have often to be pulled by animal power to be able to ferry them across rivers, because otherwise places are disconnected from many places. And I'm sure this is a problem in many parts of other India as well as African countries. And here, these two states of Chhattisgarh and Madhya Pradesh are forested, also malarious, as well as a lot of malnutrition, and there is also civil strife, where inequality and injustice actually defines whether people get healthcare or not, and what quality of healthcare do they get. So if I may just remind people, that we believe very strongly that of all the forms of injustice, not getting healthcare when you're ill is the worst of them all, as Martin Luther King said. So if I may further define what is the sustaining thing among people in Chhattisgarh is the nutrition levels, which suggest that the median weights of men are 49 kilos and median weights of women are 41 kilos, which is 10 kilos lighter than most countries, most adults in sub-Saharan Africa with HIV also. So, and nutrition cannot be poor without food insecurity. So that's a big issue. And even in that, the inequality reflects that the people of the indigenous community, primitive tribes, have much lower, BMIs, body mass index, as well as the regular tribes have slightly better body mass index. And the other, the non-backward categories have higher body mass index as a matter of nutrition. So there's a pecking order even in the nutrition, as defines the, when you define the marginalized and you want to look at them. So if I try to define what did you observe that ails healthcare in my state of Chhattisgarh, and thus what we do try to do those I'll discuss a little later. One is that the burden of disease is massive. Illnesses are high in number. Whether it is you talk about infections like tuberculosis and leprosy, I still see about 100 cases of new leprosy every year, whereas it has been defined as as a disease eliminated in the national discourse. Tuberculosis, India is the largest burden of tuberculosis in the world, but among us, it is also one of the largest problems that we handle. Malaria is coming down. Yes, falciparum malaria. It was a big issue till 5 years ago. It is coming down, but it is getting replaced by illnesses like dengue fever, as well as scrub typhus, which is an infection that is very common in Asian countries, and particularly in Chhattisgarh. Non-communicable diseases are also extremely common. I must say, I'll talk about lean diabetes later, but whether it is, the poor in India suffer from the same NCDs. They in fact have a double burden, as we call them, not only infection, but also the NCDs like hypertension, diabetes. Though the pattern may be different, but they have a lot of NCDs also. Trauma is not a small issue, and rural trauma is even a little different ball game. Nutritional deficiency diseases. So it's not communicable diseases and non-communicable, but also nutritional deficiency diseases, whether it is rickets, whether it is vitamin A deficiency, whether it is undernutrition per se, malnutrition, protein energy malnutrition. The other thing is that the health systems are poor, and I believe this. Poor people get poor health systems. Poor people get poor health systems. Hello. Poor people get poor health systems. Yes. Poor people get poor health systems, and the system is poor in quality, especially the public sector. But also people expect little of it. But there's still hope that the public sector will play its role that it should play. We also don't have a very well-functioning medical services corporation that can procure drugs and diagnostics from the market and supply to the public health facilities. And because of this, can we mute the people, others, if I can? The host can. So other
we are doing it.
Pocket expenditure on drugs and diagnostics are very high, which results in a lot of medical poverty. I would use this word, medical poverty, actually becoming poor due to healthcare expenses and abandonment of treatment. People often decide that they don't want to seek healthcare because the healthcare is too expensive. And there is no good health information system is another problem, which something was discussed yesterday, but at a national level, at a government level, in the state, we don't have it. There is an adequate surveillance system. Sometimes we would do surveillance for the diseases, but not their determinants. And information technology, computers are used for policing the peripheral health workers rather than to support them. Is another problem that I see. There are 6 medical colleges that we have, but they're involved in very mediocre quality MBBS training. So therefore, and none of the medical colleges are involved in public health practices. So tuberculosis and leprosy or maternal health is not looked up, is not contributed to by the medical colleges. And nursing courses for rural nurses has been stopped, but they want to train BSc nurses, which nurses will go away to the greener pastures. And protection from illness and impoverishment, the insurance programs are there at the national level, which is also there at our own state level, but it is only for inpatient care. And there are many administrative issues, and therefore it is not, very useful for the people when they fall sick. I must also say that there is a lack of professionalism in the medical fraternity. The system is unaccountable. If a doctor is not coming at even 10 o'clock in the morning to the OPD, there is no one to ask that person. And I'm sure this is a problem in African countries, or many of the African countries also. And there is the health bureaucracy is also not supervising adequately. There is opacity in postings of the doctors, recruitment and transfers. There's also a strong likelihood of inefficiency and corruption. People don't want to go to hospitals, to their postings in the rural hospitals, and would sit in their city clinics, and private practice is allowed. I don't know how many private medical colleges, how many countries in Africa allow public physicians, public system doctors to do private practice, because there is a conflict of interest, and because of this, there is a hemorrhaging of the system, and no one works there. So there is scarcity for some time, but there is a big problem of this thing, and also there is a very low self-esteem for the public system. There is a shortage of staff which is there. There may be political commitment, but there is no technical support unit, and actually the spirit of people in the public health system is very poor. They don't feel proud of their own health system, is what I would say as a problem. And there is no, even when you talk about the determinants of illnesses, they are not looked after, whether it is food. We have a public distribution system, but that provides only cereals. It does not provide any legumes, any proteins, any oil also. The salts and carbohydrates are given in a large amount of this thing. And as primary healthcare physicians, excess of salt and excess of carbohydrates are all very bad. Water is insecure, so we routinely get cholera in our villages, and water bodies are also unprotected in our area. Civic bodies don't do their work, so this is a problem. And we know that when we talk about our own state of Chhattisgarh, we know at a national level during COVID, the inequality has increased, and so has marginalization of the poor. So two of the richest people in this country are these two gentlemen, whose net worth have expanded, has skyrocketed almost. So I would say overall, if I want to say, the problem is that our public health interventions, there is no underpinning of equity. So if you are poor, then you don't get anything, but if you are rich, then you can get everything. And thus we wanted to address those things when we intervened in our area. So if you look at it, even theoretically, there is among the economists and among the public health administrators, there is this competition for which are the concepts which are of more importance. Equity is more important, or its efficiency. Oftentimes we want cheap and affordable public health interventions. That is true. We must go for it. But this new buzzword that economists talk about, cost effectiveness, I think we should first talk about effectiveness and then talk about cost effectiveness. Because if in the garb of cost effectiveness, we reduce the effectiveness of our intervention, then it is not a good thing to do, is what I would say. So, and humanity of health services is also very critical when you're working with the very poor. So I would say, if there is a competition between equity and efficiency, who should trump it? I would say clearly equity should be allowed to run ahead of efficiency. Efficiency is a lower quality concept that should be looked at, rather than don't allow our managers to sort of insist on efficiency, but compromise on equity. I would say this is a lesson that I would draw through many examples that I would take on now. So in the space that I worked in rural Chhattisgarh in central India, we believe actually in primary healthcare, in the broadest concept of the concept of this word phrase. So all common and important problems. It's not just a few problems, that you berry pick as part of selective healthcare. Equity has to be there. Cost, quality, and access are all important. But the fact is that this care has to be there with all these underpinnings. And I very strongly feel that primary healthcare is not only primary level healthcare. If someone with snake bite requires ventilation to sustain the breath, the breathing, that is a secondary care facility. So be it. That is also primary health care. Whether it is provided at secondary level is another thing. And secondly, primary health care is not second-rate medicine for the poor people. That is immoral medicine. That is not even primary health care. And it is not straight-jacketed protocols for regimes. So if you know this thing, that if you get leprosy in US or in Latin American countries, you get rifampicin, the drug called rifampicin, every day, because that is one of the most important drugs for leprosy treatment, like in tuberculosis. But when you get leprosy in India, you get rifampicin once a month. Are we different animals that we should be getting such a thing? So if that is if principles of of straight-jacketed protocols are not they trump efficiency and effectiveness, then this is not fair, is what I would say. And I would leave these many questions with you for later. So I would say, the approach that we followed, and I would talk about more in this, that's when you find solutions to public health problems, simple solutions are certainly the best. But if the optimal solution is complex, so be it. You can't scale up by dumbing it down, is what I would say. So, the hospitals that we ran are extremely busy. There's a waiting queue for 1 week because we try to provide effective care for all the common problems. Beds that are, that are also full. Drugs that are given, with pictorial slips, which can reflect for night, day, lunch, and early breakfast time also. And we have laboratories, a very important component of healthcare. So whether with a microscope, centrifuge, and a colorimeter, you can do most of the healthcare, most of the laboratory things. And we do even higher end cultures. This is the TB bacteria growing on LJ medium. And even peripheral community things I will talk about, the technology. So, and even developing technology, things like, this is a stethoscope, which has a single chest piece, but there are two pieces of earpieces. So there is a trainer who's training a peripheral health worker, teaching how the heart sounds look like. Or even in this example, this is a pediatrician friend of mine who's also giving anesthesia to newborns. So, because you don't have so many specialists, so you have to despecialize or multi-specialize in a case, so as to provide primary health care to the people. Because expecting this newborn from an Adivasi child to go to a city hospital is impossible. So let me now take about 6-7 examples that I would now focus on when I talk about discussing the point that I have tried to make out till now. Let's talk about tuberculosis and what I would call hunger. Hunger, if you know, is a sanitized word for malnutrition. Sorry, malnutrition is a sanitized word for hunger. Let's call it a spade by what it is. Let's call a spade a spade. So malnutrition is essentially hunger, chronic hunger. So if you look at what Government of India says, or even WHO says, that hunger contributes to tuberculosis, 55% of tuberculosis. HIV only contributes to 1%. I know many African countries, they would say that HIV contributes to, say, 20% or even 30% of tuberculosis patients in their country, maybe 50% also, like in South Africa. But in India, it is only contributing to 1% of tuberculosis patients. Diabetes contributes to 9% of our tuberculosis patients. Smoking contributes to 5%. Hunger contributes to 55% of our tuberculosis in India. And India is the highest burden tuberculosis group. So in our Chhattisgarh state, as opposed to the worldwide known of multi-drug resistant tuberculosis, this word called MDR. In Chhattisgarh, MDR is malnutrition first, M for malnutrition, D for diabetes, and the R for HIV, in that order. So we have to, understand malnutrition if you want to, and address it if you want to manage tuberculosis in Chhattisgarh. So this is a man who came to me when I was sitting in an OPD with my weight of 61 kilos, and his weight was 28 kilos. How can I talk about just giving anti-tubercular treatment to a person like this when someone is, having a weight of 28 kilos? So food and our tuberculosis work became tuberculosis and food work. So these are some of my other pictures of patients with tuberculosis. With these weights that you have in tuberculosis, how can you just talk about anti-tubercular treatment? Or this is a family of 3: the father, son, and the daughter, all having tuberculosis at the same time, sputum positive tuberculosis. And my median weights of my patients are 42 kilos is a median weight. That means 50% of people have weights lower than 42 kilos. This is in men. In women, the median weight is 34 kilos. That is the weight of an 11-year-old child. My daughter, when she was 10 years old, she had a weight of 34 kilos. So, and this is the weight of adult women with tuberculosis. So, what this shows is adult undernutrition is something that is not talked about, because whenever we talk about undernutrition, we talk about childhood undernutrition, but adult undernutrition has to be understood and addressed also. There is a complete whitewashing in the national and the international discourse on undernutrition. I think it has to be brought back. So we have sanitized the word hunger to call it malnutrition or undernutrition. So I would say, we need to provide food for TB patients, and that is one program that we allowed the Chhattisgarh state, my state government, to say that they will provide additional food rations to all patients with tuberculosis besides the national food distribution program, so that their tuberculosis improves better. And I must say with some pride that this program has been taken on by the national program in India, who have decided to provide some money for food. I don't want to provide money for food. I want to provide food to my TB patients. But I think that is an idea that we need to take on in all our countries that we are, we are today together discussing about tuberculosis and undernutrition, whether it is due to HIV or whether it is due to malnutrition in our different countries. I will quickly jump on to the next idea besides the TB and hunger that I've talked about. So, in India, indigenous communities are called Adivasis, that we know. So the question that comes up is, the national program for the indigenous communities says that we should have exclusive facilities for the indigenous communities in health facilities. And they would provide funding for that, for organizations that want to work. Or the question is whether we should have, a general facility, a universal facility for everyone even in tribal areas where there are tribal indigenous communities staying. Should the facilities be available for all, or should they be available for only the Adivasis, is the question that we asked ourselves, and we provide the answer to this in future, in like this. Look, health facilities, if you talk about health facilities planning, poor people's programs, which if it is only an exclusive program for the poor, it becomes a poor program. Whether you talk about the staff, the least qualified people are put into wherever their communities are only of poor people, space is given less, there are fewer drugs, fewer diagnostics, and the highest trained people or highest facilities are given to people who are in cities or who can demand the resources for themselves. So we were also tempted to run exclusive clinics for the poor, for the indigenous communities, for the marginalized people, because there were funding attached to this, but we resisted this. I would say very clearly, we should run services for everyone together in a poor area, but you can give preference for the people who are indigenous communities or who are poor, who are marginalized in any way, but the services should be open to all. Otherwise, they will become poor programs, is what I would say. So whether you can give more subsidy to people who are indigenous communities or marginalized people, and they can have a green card, which is like a, Americans, you get a green card to reach there. I would say a green card to enter the premises. So anyone who, an Adivasi or an indigenous community person comes to a health facility, they should be able to enter. They should be able to enter the premises and meet the senior most doctor at any time without, waiting in a line. Is what I would say very clearly. So, because poor people can get poor health systems, I do not want to have health systems which are only for poor people. It should be for everyone, but poor people should get a preference there, is what I would say. Whether it is Adivasi, indigenous communities in India, or otherwise, people who are marginalized anywhere else in our country or in the world, is an idea that I would leave for all of you to ponder over. So I move on quickly to the third point that I want to make as an example. I want to make this provocative statement. I know there are many countries who are participants from who are here today, who are talking about where there is a lot of malaria and malaria deaths also. Malaria, I would say malaria deaths and snake bite deaths start where political power ends for the poor people. Malaria deaths don't happen among the people who are well off. Snake bite deaths don't happen in cities. And where political power, has a sort of a centrifugal, centripetal sort of a focus. So, where political power ends, malaria deaths and snake bites increase. And I would say, if you look at it, there is snake bites and deaths due to it. There is almost no research done in the last 50 years in the world, because there are no roads, there are no vehicles on those roads. Oftentimes, communication for the people who are staying or sleeping on the floor in poor areas, these are the things that are missing. And even if you look at the doctors or nurses who are posted in indigenous community areas, have poorer skill sets. They often don't know how to use anti-snake venom. So, and supply chain for drugs are also poor in these areas. So I would say, this is one area that we got into. So when I was working in Delhi in a medical college, I had not treated more than 2 snake bites in my entire 20 years that I spent there. But in the last 20 years that I spent in the marginalized areas, I treat about 500 snake bites every year. And mainly it is through my peripheral health workers, and we train people. This is the commonest snake bite that kills in India, the crate. And we train people, our health workers, and my village health workers at a senior level can manage snake bites and give anti-snake venom and even manage these people. They don't even require doctors to do it now. But I want all my doctors to be trained also. And I think snake bites, no one should die, even if people get snake bites. Yeah. The fourth idea that I want to discuss now with you when you want to plan health services for the poor and the marginalized is, what is the role of laboratory in healthcare? Often, laboratories are there in more well-resourced health facilities, because they say that they need lab technicians, they need AC, air conditioning, they require machines that are large, maintenance is necessary for those things. So I asked this question: if Muhammad can't go to the mountain, that is, if the people who fall sick, they cannot go to the city laboratories or big health center laboratories or even health facilities, can mountain go to Muhammad? So that can the laboratory go to the people? So here is an example. What we did was, we trained all our village health workers in the community in making blood smears for malaria. This is a time when we did not have rapid kits. So they would examine someone. In a village, and they would make blood smears on their own. We taught them how to make thick smears. Then these smears would be dried and wrapped in pictorial forms, and they would give these forms to young girls who would go to main road villages, which have schools, which have buses. The big schools are there in main road villages. Only 22% of my villages are connected by a road. From all the other villages, the girls who would go to a main road school, they would take the blood smears from their health workers of the village, and leave it at a roadside shop. And buses in India ply from villages to cities in the morning, and they come back to the villages in the evening. So they would take these blood smears in boxes, soap boxes, and leave it in the hospital which is on the way in the city hospital or a big village hospital. And these would be reported in very quick time, within 2 hours. And the reports will be sent back with the buses that are now going back to these children who are now going back to their own villages. And they would leave their reports with the health worker, with the instructions from this thing. So even if even if we did not give microscope to each village and a technician to there, but we could give the report for malaria and other things by this slide courier transport system. So why not? So, laboratory investigations and primary care are so important. It is one of the most neglected areas of component of primary healthcare. An effective use of diagnostic investigations, that was also talked about day before yesterday, can reduce cost, rationalizes, and improves the image and the acceptability of treatment offered by the public health systems. So, we must say that, the slide courier system has worked very well, and other point of care tests can be made available. And if there is a confusion, then they could be mentored by technicians from the cities. And I think all they should be used at a community level, whether it is pregnancy testing, whether it is dengue diagnosis, whether it is scrub typhus, as I was talking about, whether COVID now and tuberculosis and glucose levels could be checked by the point of care test for which they are available. And the rest we should keep on making through our innovative technology. And otherwise, I must say, there's a lot of mysticism about laboratories. A microscope, a colorimeter, and a centrifuge can do more than 90% of lab tests that are needed. The fifth idea that I would want to take is, in India, because among the very vulnerable, the very primitive tribes, the government of India banned, terminal contraception for them, because they felt that they should produce more babies, and because their numbers are going down. This paradigm that you feel that let women produce more children so that some will survive is a very wrong idea, because it is against the principles of equity for a woman who's a poor indigenous community woman. So they will continue to have high birth rates and high death rates to maintain their numbers, which is a very bad idea. I think we should run good services so that their death rates are reduced first, and then birth rates should also be reduced by offering women terminal ligation. So we went to the government of in Chhattisgarh's High Court and filed a case against the government that we must allow surgeries for birth control for pregnant women, for Adivasi women, for the tribal community women, and we won the case on grounds of equity. So I think we should have good health facilities as well as birth control facilities for the indigenous community women. You cannot just say because we are not giving them good health service that they should continue to produce babies for all their lives. So I would now go for another idea now, if you have patience for that, is the idea that I was talking about adult undernutrition, but the other idea is that there is a lot of adult under child 3 malnutrition. And under 3 child malnutrition is because it happens because and particularly it's one of the largest problems in healthcare. The reason is that children, after their mother's milk is not adequate, that is at 6 months of age, they cannot get adequate top feeding because there is no one to feed the child, because the parents have to go for work, and there is no child friendly liquid food that is available or semi-solid food. Adivasi women, indigenous community women, and village women have to work far more than other women in cities. So women in cities get creches for their children, and the men also get creches for their children. Why not rural women? Creches can provide the desired food, a safe place where parents can feel secure that when they go out for work, the children are being looked at, and early childhood education can be also given to them. And in India, the other bad thing that happens is often an older girl, brother or sister, a sister is, asked to drop out of school to look after this young child, to look after safety and some feeding of this child. And she then drops out of school, this girl. So we started running village creches for 8 hours every day, which offer the job for a village woman and she was asked to look after 10 children at one time, and all to do this for child feeding. And this improved the level of the care for the young 3 child. And India, otherwise, the other program for the child feeding program is only for 3 to 6 years of age. Tamil Nadu did it very well about 30, 40 years ago. But the rest of India, like my poor state, has not been doing it till recently. So we run full day creches. It prevents undernutrition in the children under 3 child. It allows elder siblings to go back to school, and it allows working parents to earn wages in peace. That is, all these 3 objectives are being followed, and I think this is a great idea that many of you can take on in your own areas of work. I would now talk about one idea for the HR. Healthcare is largely hospital and doctor focused, but we know that that is a problematic thing. So there are 3 ideas that we curated out in Chhattisgarh, which have now been taken by the government of India to implement in the rest of the country also. And those are, we first developed the health outpost called health and wellness centers, not only for diseases, but even for wellness, where a non-physician health worker would look after the most of the problems that a village health worker cannot handle, but even more significant problems. So we fostered and supported so-called mid-level health workers, not just community level village health workers, but also not only doctors, but mid-level workers who are non-physicians, but are more competent and more trained to look after the absentee doctors. And thirdly, to support peer support groups, that is, groups formed of people with a common disease, which can discuss things about each other, and these are led by a facilitator like a nurse and some expert patients. So this is developing the human resources for disadvantaged people, mid-level health worker. Doctors are not going to go to rural areas in any significant numbers. It's something I'm convinced about. I don't know whether my African colleagues are convinced or not. I hope they are. We don't have a model for non-communicable diseases in this country, in India, and I'm thinking it's the same true for most other African countries also. We can have for maternal and child health problems and infections like malaria or pregnancy, where there are labor rooms and hospitals, but for illnesses like diabetes, hypertension, rheumatic heart disease, there are no community programs that are there in the community. And this space of the mid-level worker is taken up by the informal practitioners who are not often qualified, and they look after these problems. Mid-level health providers can contribute to maternal and child health problems also.
Audience, please mute your audio. Audience, I request the audience to please mute your microphone. Kindly, please.
So Asha, the village health worker can only do so much. She is not a Durga, that 8-handed woman who can do after everything. So we need a mid-level health provider, and therefore, we have to break this hegemony of the physicians in public health. And this is something that we try to do, and with an idea. So we did this even in community mental health care. We know that the doctors insist, psychiatrists insist that a patient with a major psychiatric disorder, they should come to the hospital for starting their illness. But if the hospital, if the person, and oftentimes people with major psychiatric disorders don't want to go to a hospital. So what should we do? Can't the doctor or a non-physician health worker go to the house of the person and start treatment? So this is what we did. People went out to the families, and they would record video interviews or handwritten records, and then they would consult a doctor and start treatment on there. And when people improved, then they could come to a hospital for continuing treatment. So we also asked this question: how do you provide help and counseling for rural people who attempt suicide and are at a risk for repeated attempt? So we ran such programs in our own community program. And I think these are ideas that I would offer to all other people who are on this call today. So peer support groups in health. One of the bigger problems in community are these non-communicable diseases like sickle cell is there in many other African countries also, like in Chhattisgarh. Alcohol dependence is a big problem in many poor people. And so, shifting power to the people through making support groups is, we found that the compliance rates with treatment which is only 20 to 50% in most chronic illnesses, improves to over 90% when you give the power to the people. So these people with common illness would meet once a month. They would discuss about each other's problem. And, and we have now found federations of these people with a common illness, and the compliance rates with drug treatment went over 90%. And these people, once they get power of the group formation, they can demand for their rights from the state, from the public system. So we have formed 54 such groups, and I think Tamil Nadu has taken the idea from us and now implementing at a state level in their own state. Illnesses such as alcohol dependence, diabetes, hypertension, mental illnesses, epilepsy, sickle cell disease, arthritis of the younger people, asthma, other lung disorders. They form groups of their own selves. They meet once a month. They share their news. They support, drug taking issues. They discuss about a new thing. They play and do some physical activity. They also do some savings program, and they take up some livelihood work together. They also have some common food together, and also try to find people with the same illness in the community who are not taking treatment. So, and bring them into the treatment fold, and they can become the greatest advocates of their own problem with the state. So possibilities are massive. The peer support groups can become health coaches, and they can become public health advocates. And I would say this is an idea that all of you who are working in community programs should consider supporting your chronic illness programs. And patient support, patient group centered care can achieve so much that professional led healthcare can never achieve. And so I would say I would now go on to the final few ideas, and then I would rest my case. I would ask this provocative question: is privatization a direction for public health? We asked this question to ourselves, and we came with an answer. The answer is no, a big no. And how? Privatization for me is a direct outsourcing of funding from the public system to there is this thing buzzword called private-public partnership, where the public pays, but the private provides, and money is all given to the private sector for providing healthcare. It has not worked anywhere in the world. No country in the world in an unequal society. Public financing ke bina, without public financing, an overwhelming of care has to be provided by the public system. I know our public systems often fail. They should be criticized, and we all criticize our public system. But you can't throw the baby along with the bathwater. The public system has to function. There is no other option. That is what I would say. And there is no country in the world, I would repeat again, which has provided healthcare for all its people through a privatized healthcare model. I know there are many economists on this call, and I would challenge them in a sense. So whether privatization is of a private pharmaceutical industry, or health insurance, or medical education, private medical education, all are some things that are not things that should be supported, in my opinion, when you are talking about primary healthcare for the marginalized. So sickle cell disease is a problem I know many African countries also face, particularly in both East and Western Africa. It's a genetic disorder which evolved due to falciparum malaria, which is prevalent in our areas. And indigenous communities and non-indigenous communities both suffer from this problem if they are in these malarious areas. Overall, the mortality before treatment started was 25% by age 18. So if there were 1,000 children born, by age of 18, only 750 remained. outcomes of chronic complications and acute frequent pain episodes and deaths due to happen like this. But now the drugs are available and outcomes can be, the people can live beyond till 60 years of age also. So, but if you are in India, if you are a indigenous community person, you have a very poor chance of surviving sickle cell disease. But if you are a non-Adivasi, non-indigenous communities, then you have a better survival. This is because, illnesses are biological embodiments of deprivation, of marginalization, and something we should address through technology, as well as, taking politically correct decisions about healthcare. So I would talk about briefly about an illness called lean diabetes that I see. We see as many diabetes as we see in Chennai or in the New York or in London. But our type of diabetes is a different type of diabetes, which is where people are continue to be undernourished. They become more undernourished and get diabetes, and they require often insulin for care for their diabetes control. So they didn't have any faulty lifestyle of, they did not have much carbohydrates or much food. They did not gain weight, but they developed such a problem. These are the type of diabetes patients. This is my normal lab technician, and there were 3 very undernourished women, all 3 with diabetes. And this diabetes is of a different type. These are also 2 people, brother and sister, due to diabetes. So this, we call it lean diabetes because it is undernutrition along with diabetes. So 70% have a body mass index which is lower than 23. In fact, 40% are also severely undernourished. 50% require insulin for their care even in the first few years of treatment, and their blood sugars are very high. So this is a type of diabetes that has to be still understood, but also managed correctly. And it is a nightmare challenge measuring it. I just leaving it for some of the people who are more interested in managing complicated problems in our areas. And I'm sure, I know Ethiopia has a lot of lean diabetes also. Maybe other African countries also have it, but Central India is full of lean diabetes as a problem. So I would finally end by saying that, the other thing that we should do when we're talking about healthcare for the marginalized is to ask the right questions, not just find the right answers. So what is the burden of disease from the poor suffer from is something that we still don't know, because we don't collect data on grounds of this thing. What is the healthcare package that should be there at each level of health facility should depend upon what are the problems that people have and which kill and which maim people. There are so many technical questions in the care of diabetes, tuberculosis, and malaria and leprosy that should be answered. What about the role of food and illnesses? Why don't we have price control over essential drugs? Should tertiary care be supported or not? How and whether we should handle NCDs? Should conditional cash transfers be is the way forward? What is the best way of for human resources in health? Should we produce more MBBS doctors, or should we have non-physician health workers who should be supported and trained? And I would end by saying that, these battles against diseases will have to be fought and won or lost in the wide varied expanse of rural areas that countries in Africa and Asia have in large abundance. And this is the areas where the foot soldiers are absent. They are poorly equipped with ammunition, supplies, and communication systems and backup. And we know that most poor people and most people still stay in rural areas in our world. And the burden of disease and its effects are clearly more among this thing. And that's what is a choice that we have to take. I would urge you to consider that life is all about making choices, and whether when we work for the health problems of the poor in the marginalized is the way forward. And this lens is something that I would recommend whenever you decide about whatever technology that you want to make in healthcare. I would rest my case here and would welcome questions if there are any.
Okay, thank you very much, Dr. Yogesh. I'm sure the participants had many learnings from your experience. I have 2 or 3 questions from the chat box. I would like to read out one by one, and you can address them in your one. So there is a question from one Eric Lesvancio. The question is, I would like to learn more about how the blood smearing technique works. How the blood smearing technique works. We are trained community workers in integrated community case management here in Zambia. Sometimes, though, there have been challenges with supplies, especially RDTs for malaria testing, which hinders their work. So that's the comment plus question. So you like to respond?
Yes, I can. So I would say, the gold standard of malaria testing is a thick smear examination. A thick smear examination is like a drop of blood. If a finger prick is pricked after cleaning, finger is pricked after cleaning with alcohol. With a single needle, you can take a drop of blood and put it on a glass slide, which anyone can learn, any health worker can learn with a couple of days of training. And a size of a old, a pound coin, or in India, a 25 paise coin, size of a gold of a thick smear is made. And this blood drop is made to, after smearing blood on this slide, glass slide, if it is allowed to dry, then it can be stained another time, maybe, or if the laboratory is, if it is close to where this sample is drawn, it could be it could be stained and then seen for the malaria parasites. And then you can count the number of parasites in the number of fields that you see through a microscope. And this is a skill that can be learned also quickly. Now, because it requires a skilled microscopist to read this blood smear, over time, in the last 10 to 12 years, we now have rapid kits which use a technique called lateral flow technique to diagnose malaria through a rapid kit which can be done by an untrained health worker, also by a less trained worker. These tests are not as good, but they are reasonable as a thick smear. They have some problems that once, if they are turned positive due to a malaria infection, they don't become negative for another 3 months. So if you get another infection 1 month later after the first one, then rapid kits are not as good. And I would say, but rapid kits are here to stay. The test that is done like a point of care test without a lab technician being there. And but when there is a controversy, or when there is a repeat infection happening within a month of previous infection, then rapid kits have their limitations. And therefore, microscopy testing for malaria will continue to stay with us for times to come. But rapid kits will become the first line test, I would say. And but you have to insist on good quality maintenance of microscopes and the skills that people have, as well as these kits. These kits often become bad in very hot climate, like above 40 degrees Celsius. These rapid kits will lose their potency.
Thank you. Here is a big question from one Mr. Modu Gaye, because you talked about hegemony, breaking the hegemony of doctors in public health. He's asking you again, how can we break that hegemony to improve primary health care and service delivery? So he's posing the question back to you again.
I wish I had a good answer, but I would say, it is something that, it cannot happen without including the people who suffer the illnesses, that is the community at large, to be a partner in providing healthcare and taking decisions about their own healthcare. Oftentimes, whenever there is a health committee, it is usually the senior physicians who would make the decisions. So what are the illnesses that should be researched? What are the health systems that should be there? if the doctor is not not coming to a clinic as expected, they would still get wages. They would not have any accountability. So if all those different measures is something that we can break, if we are implement those, then these are ways to break the hegemony. And I suggested also this, communitizing healthcare, where you transfer the power locus from the doctor. For example, at the moment when you go for drugs to be taken again for any illness, like say for your hypertension, every time you go to a doctor and the doctor will give you a prescription, he will or she will spend with maybe 1 minute or maybe sometimes 5 minutes with you. But and oftentimes you are not able to ask the questions to them about your illness, and or the doctor does not have time, whatever. But if you transfer the power and make peer support groups of people with hypertension from a single village or from a single locality, and they meet each other, and hypertension medicine distribution for most people who are responding well to the treatment is something that does not require a doctor to be there for each time when you consult. And one can have a group discussion about hypertension when such a thing is happening. So why not go for such a thing? Is peer support groups will be a wonderful idea to transfer the hegemony power from the doctor to the community of sufferers. And I think communitizing healthcare through other ways, and I would say there will be some legislative changes will have to be also done. So I think it should be taken at a political level. So, for example, in India, no one but a physician is allowed to prescribe any drugs. Even in unequal countries like USA, there are nurse practitioners, there are physician assistants who can prescribe medicines of certain types. But in India, no one can prescribe anything but paracetamol, like a doctor. No one is. So, but we have to change the Drugs and Cosmetics Act which is a legislative act, in the parliament, and those would be other ways of changing the hegemony, because we are electing those legislators. So why don't we make those changes in the legislation also? Some other things I would say.
Thank you, Dr. Jain. There is one more question from one Mr. Solomon Jetta. I'm not sure which country is from. So there are two questions he's asking. Our country is about to launch a national health insurance scheme. What do you think should be the position of PHC in the scheme? And the second question, I will read out now, you can consider them. He's saying, how can we reduce staff attrition rate in primary health centers? These are the two questions from Solomon. Place of
so the first question is,
they are planning to launch a national health insurance scheme. What should be the position of primary health care in this scheme? So you have made a reference to that in a way that our insurance scheme doesn't cover primary care. So he's asking, if you were to integrate it, how would we go? If we were to bring primary health care under the national health insurance scheme, what can we do? How do we do that?
So I would say, I don't think this is for India, because India already claims to have set up a health insurance program, Ayushman Bharat, for last 4 years at least. And he's from the Gambia, he's just now. So, but I must say, if there is also still a debate going on in the Gambia, I must say that, insurance programs, insurance-based programs have inherent problems in healthcare provision, universal healthcare, because there are a lot of problems about moral hazard and other things, and the fact that people who are who can't pay the premium, then they will not be able to get the healthcare, and it breeds inequality. So if there is a social insurance system like in Canada, yes, there is a possibility of getting some healthcare for everyone. And I must say, the other problem with insurance programs is that they're largely medical focused, medicalization focused. They're health procedure focused. For example, India, the insurance programs don't have outpatient care being supported, which is also the major cause of expenses in chronic conditions. So if you only have inpatient facilities being supported, inpatient care being supported by health insurance, that is not, that's not comprehensive health care. So that is the other problem. And preventive care is something that no insurance program is ready to support. So I would say argue that insurance programs don't lend themselves to comprehensive health care, and thus are not the way to go forward. I think the best model that we can learn from is the National Health Service, National Health NHS of UK, or the Thailand model of healthcare, which is universal healthcare through tax-based financing.
Okay, there is a question from one Mubarak Ali. He's asked 2-3 questions, but I will pick one of them where he's very particularly interested in knowing about the access to healthcare for underprivileged program, AHUP, which is being run in the state of Chhattisgarh. Can you let us know the role and responsibilities of this program?
Access to healthcare in?
It's called Access to Healthcare for Underprivileged Program, AHUP.
No, I don't know of any such specific program, but there are two separate programs that they run, where they run some village hamlet based outpatient services that they run. Otherwise, Chhattisgarh still only is trying to implement the national health insurance program, the Ayushman Bharat, in its own version, and it is therefore an inadequate program in Chhattisgarh still. Yes, they do run some mobile medical units in some areas, but that is hardly partial care for those conditions that show up on that same day, and it is not it does not provide continuity of care, and there are many other problems with these piecemeal programs, I would say.
There is a interesting question from one Mr. Andy, saying in rural areas, first point of care are usually people like shamans, local healers. How do you see their role in providing primary care or being part of the system? The role of shamans and healers, local healers.
Well, I would say they also have a role, but so if there is a village committee that is formed, village health committees, they should also be. I think you should involve them. We have been using shamans and other faith healers in improving care for, say, snake bite care. Often people waste time in going first to a faith healer, and in snake bite, time is of essence. So in fact, we have often suggested that faith healers, if the people come to them with snake bites, they can bring them to the hospital and continue to provide faith healing programs, while we also do our own bit about following up people, and have a partnership in a sense in managing people together with snake bites. Otherwise, I must say they also do provide certain services in terms of counseling for some common mental illnesses, as well as I would not dismiss them, but I would not sort of glorify them either. So that I would still engage with them and include them in improving access to care, because they do enjoy some amount of respect. But I would engage them. Yeah.
If I may intervene in your own region, are there such traditional healers in the Adivasi areas where you have explored? Have you had any experience working with them and being part of your delivery system?
Yes, for certain developing certain herbal preparations along with them. Some Kavirajas have been involved, as I mentioned, in snake bite care, and in approaching, understanding about, exploring with them about the science of of human body and human illnesses is something that we have discussed with them, and included them in in shared training of people or health education also?
There's one other question from one Miss Sirisha. Since you discussed extensively about the undernutrition, hunger, and so on, she wants to know how well this nutrition rehabilitation centers that are part of the Government of India program, how well are they functioning in Chhattisgarh? You have about several of them there. What has been
so yeah, they are at each block level and each district level also. So they suffer from huge issues here because these people, these places, often try to manage people with children with severe undernutrition, but where they fail is that when the person goes back home, the child goes back home after 2 weeks of spending in the nutritional rehabilitation center, even if the family is being supported during that period, the problem is that once they go back, they are likely to slip back into the same situation that they started with. So therefore, such institutional programs for severe undernutrition are not only unpolitical in a sense. They're not unsocial in a sense that they don't understand the reasons why undernutrition happens among the poor people. The same reasons why undernutrition was there in the first place, they return back once that 2 weeks of this honeymoon period is over in the NRC, in these nutritional rehabilitation centers. And I would say we should look at more community-based models of managing severe undernutrition. Those who are sick with undernutrition, if they have a superadded infection, they obviously require hospitalization and care, institutional care. But I'm not a great fan of these nutritional rehabilitation centers. They have very limited role in certain people, not in the largest number of people, and not for all the people in certain other times of as a continued form of care.
A very general observation on the nutrition, even the state of Tamil Nadu, where the overall material average income has been pretty high compared to other states, the wasting has not come significant. Wasting is still, compared to last NFHS 5 even shows that wasting is pretty high even in such states where you have had long experience of nutrition scheme as well as average income. What could be the wasting mean? Basically, you've probably not had food for at least 2-3 weeks and it is losing a weight. How do we explain that? Because your income level is also going up, not spending adequately or eating the right thing. What could be the possible reason for even better off states like us? Wasting is still hardly, it has dropped 1 or 2%.
So I would say one reason why wasting happens, which is something that we worry in all wastings people, is whether they have an intercurrent infection. So I think environmental reasons for say poor quality water, or if a child has acquired a pneumonia or a urinary infection or some other infection or a helminth infection, is something that would be an additional thing. So focusing on just food and income may, if we have escaped, focusing on illnesses, illness prevention and illness care besides the food bit. I think that could be one reason why we should why wasting can happen, because wasting is due to acute loss of the weight, acute loss of weight due to catabolism that happens due to infections. Otherwise, I think if there is a poor quality food, then that should affect more, both. It should cause more stunting, I would say, rather than wasting.
Oh, I see. Okay. It's not merely not having lack of food; it could be other reasons.
Yeah,
there's a lot of us.
Must be first would be infections. I would say first would be infections. if people are getting infections that are not being picked up in time, or they have more chances of infection, they can cause wasting in 2 weeks. Whether it is serious illness like tuberculosis, or a chronic, or a simple illness like diarrhea, or even pneumonia.
Okay, so any other questions, comments? I'm not seeing any other fresh questions on the chat box. Perhaps I will ask one question since we have a few more minutes.
Yes, yeah.
Dr. Yogesh, in your own context, there's so much of commitment and in improving the access to primary care. Are you also making use of the clinical insights and in a socio-economic context for what shall I say, for disseminating by way of publication? I know you do a lot of presentations and so on. If on behalf of our friends from African countries, I'm just posing the question to you that is there any other material that they can download from your website that can help them understand your efforts in the past 10 years, which they can try to adopt some of them? So this is a very general question to you.
So I think
all your experiences recorded. I have been through your website, so that's why I'm asking this question.
Yes, people who work often find it a little, we sort of slacken on publishing. That was a case at least in the first 10 years of active work outside the academic center that I worked in. So, but in the last 10 years, I have been publishing a little bit on tuberculosis care on hunger and illnesses, as well as on selected aspects of primary health care. We also brought out I would say a wonderful book called Atlas of Rural Health in 2016, which captured the political economy of illnesses examined from a illness window. So we took 50 stories of patient stories, and then understood we went back to them and their villages to understand in a pictorial and a more exploratory way of what caused their illness, and that was our so that is available still on as a publication on Amazon also.
Okay.
But otherwise from us. And the other is I recently have brought out this book on COVID-19, view from the margins, as it were, which tries to capture the technical aspects of the illness or the health system's consequences, or the economic consequences, or the administrative consequences or legal consequences of impact of the problem on the poor in the country, choosing the various axes of marginalization, whether it's geography, caste, gender, and that book has just come out about a few weeks ago. It's called COVID-19: A View from the Margins.
So our friends here, the participant can download from your website, from your
website may not have it still, but I can. I'm just going to. Book is not available on the website, but it's available in the market at the moment. But
okay,
I'm forwarding a.
Give a reference to us. We'll post it to our friends.
Yeah, I'm putting it in the chat box. But
yeah.
The other book is called An Atlas of Rural Health.
Atlas from rural. Oh.
Of Rural Health, Chronicles from Central India.
Very nice. So I also see a number of people who have expressed their thanks to you for this wonderful presentation. If we have a few more minutes, but since I see no more questions. I see your posting, Atlas of Rural Health. I request the participants.
I would be happy to. I would be happy to sort of engage, with colleagues who are on this call at a.
So I request Vinod to unmute them, and participants, if you wish to ask directly, engage with Dr. Jain, Yogesh Jain now, please do so.
Okay. Thank you, Professor. Yeah.
Just mention your name and country and post the question. Please go ahead.
Okay. Thank you. Can we end up the session now?
Who is speaking? Hello.
Hello.
Who is speaking?
Yeah, this is Vinod.
No, Vinod, don't end the session. We are waiting for participants to engage directly with
okay, they can.
Yeah.
Okay. Dear participants, if you have any questions, then you may ask directly. You can unmute and speak.
Questions from the participants, there are about 70 of them. Feel free to post your questions directly to Dr. Yogesh. No questions?
Any questions?
Thank you. Thank you.
I see many people post the question, and I read out. I'm sure Mr. Mubarak is there, and he's the most active participant. You may want to post the question directly, Mubarak.
So, hello.
Yeah. Please introduce yourself.
Yes. I'm. Hello.
Please go ahead.
You can talk. You can go ahead.
Yes. I'm a PhD scholar from IIT Madras. I'm working with Professor Muralidharan. I hail from Chhattisgarh, basically. So we have been looking at the nutrition status of women and children. So for women, we were looking at the anemia levels also, sir. And we didn't find much difference. And it's not only in the very marginal communities, it is for across all the wealth quintiles we see that there is this problem of anemia. So span of 5 years, last 5 years. If you could comment on it.
I must say, anemia, hello, doctor, the anemia is a big problem which is misunderstood. It's not been adequately even addressed. It's not even been researched correctly. The assumptions are many in people's mind that almost all anemia is iron deficiency anemia. For we don't even know that. The guesses are that it's only 50% of anemias are iron deficiency, even in pregnant women or otherwise also. So one needs to investigate correctly. The second is, even if it is iron that we talk about,
yes,
iron problems are largely related to poor dietary quality, and there are very few foods which have good iron content. Most of them are, of animal protein, animal origin, those are which have good iron intake. Otherwise, the entire idea of cereals, cereal-based foods don't have iron at all, almost. And citrus fruits are not encouraged by many people, which I think is one of the finest ways to get absorb whatever iron is there in cereals or in vegetable foods. So, but I think I would agree with you that largely I would say that anemia is something that needs to be studied much more. And there's a decoupling of nutrition problems otherwise, protein energy malnutrition problems from anemia problems. And I think that has to be researched much better than just studying, labeling it all as iron deficiency or as
Okay.
yeah.
Thank you so much, sir.
Okay, any other questions from
Any other questions?
the audience? Yeah, please, Vinod, ask.
Dear audience, any other questions from your side?
Sir, Mubarak here, sir. Mubarak Ali. Hello.
Please, go ahead, Mubarak.
Thanks a lot, sir, and thanks for the opportunity. Respected sir, thanks for your invaluable insight and extending my sincere thanks to organizer for this opportunity. Sir, my question is, as per the statement of Union Health Minister to eliminate TB by 2025, 5 years ahead of SDG, Sustainable Development Goal target year 2030, and how it will benefit to the state of Chhattisgarh.
I think it's if someone thinks that one can eliminate tuberculosis by 2025, one is hallucinating, actively hallucinating. If you know, in the last 2 years, tuberculosis has actually increased in number because of the COVID and our poor management of tuberculosis programs during that period. Even otherwise, we are not even in the stage of controlling tuberculosis. Forget about eliminating a disease like tuberculosis, which is related to our, our food intakes, our nutrition levels. Until we set our house in order, forget about eliminating illness like tuberculosis. Not even by 2030. I think might take a century more if one wants to think about it.
The slogan, WHO slogan of eliminate TB. What is the politics behind that slogan? As you rightly said it, it is something, as you said, 100 years from now. But why this slogan now? Eliminate TB by 2030 or whatever. Is there a politics behind that? That's the thing. Why this compulsion to have this slogan?
I think tuberculosis. I think the politics is just to play to the optics of saying something big for any big illness. But tuberculosis is not going to go away till we have inequity and food inequity, at least in this world, as well as till people have adequate food. Forget about tuberculosis declining. And I would even say, to understand the political economy of HIV and diabetes that we see in the world, which is at least diabetes is increasing, if not HIV. Those are other reasons which we don't want to touch at the moment. And you can't handle tuberculosis at the phenotypic level of the disease. It has to be handled at the determinants level before the disease actually happens. And I don't see any tangible work being done to reduce the world's malnutrition or food insecurity problems. Forget about diabetes or HIV. Yes, there is some program at the moment at the world level, at the global level, but diabetes, reducing the prevalence of diabetes, no one is working on it. And certainly malnutrition is going to worsen in the next, it's already worsening in these post-COVID times, particularly in the African continent.
Maybe one more question on behalf of our participants. I visualize we had problems in, I would say, resistance from specialists in anesthesia for letting general physician, MBBS doctor to even administer local anesthesia. I'm sure, and later on we sort of managed to give some training, and then I visualize such a problem might be there in the African setting as well because of lack of anesthetists. What would be your, if you were to give some advice, what would you suggest they can do to overcome the anesthetist shortage and scarcity of anesthetists in the African context? Whom would you train?
Yeah. So I think one can access one global law that follows that all countries that are signatories to universal covenants would be would have access to, is the Good Samaritan law. If there is a person who is there at the site of an illness, the most competent person should be, depending upon what that you will only mean some benefit to the person. And if you don't have an anesthetist, but if you can provide anesthesia and manage the problem, it should be done, and you are legally protected from that, from this thing. So this Good Samaritan law can be invoked even in whatever situation that we are, is one. The other is they are technical things like if the state legislation anywhere allows people who are non-specialists to sort of learn a certain skill, and with or without a certification, and so then it has to be fought at a political level. This this hegemony of the specialist. We talked about the hegemony of physicians. I'm talking about hegemony of the specialist. We don't even allow basic general physicians to do things. So I think there are many battles to be fought. We need to choose our battles while we fight the war, if I may say, at the right time.
Okay, Mr. Vinod, you can just ask once more if there is any question.
Yeah, we have a questions from Eric and Omer.
Yes, please, Mr. Eric, go ahead.
Thank you very much. I am from Zambia, and I am currently working on a malaria elimination project right here in Zambia. I appreciate your sentiments on the realism of eliminating tuberculosis. I just wanted to hear from you how confident you are, or how realistic do you think that malaria elimination is possible globally? Where I am working in Zambia, I think we have significantly seen a reduction in malaria prevalence in two provinces, that is Lusaka province and Southern province. And we are working in two very high burden districts. But from a global point of view, how realistic do you think malaria elimination is? Thank you.
So, if you ask me about the possibility of elimination, I think malaria is far more eliminatable than tuberculosis is, because the determinants are not so much socio-politically determined than as in malaria as it is in tuberculosis. Yes, it is still also, and it is not that it is not dependent upon the politics. We have a lot of work done by people like Sheila Zurbrigg, who talked about how malaria mortality was also a marker of about the politics that happened about the germ theory and other things. So, but I would say malaria might eliminating in the short run still seems difficult, but it might be restricted to a fewer number of countries. That might happen globally, and within those countries also that might be sequestered in certain provinces, like it is already happening in India that I know of. The disease is spread, reduced everywhere, including in the high burden areas, but it is still there in some parts. So Zambia might eliminate malaria, like Sri Lanka has eliminated malaria in South Asia, but some other African countries may not be able to do it. That may also be there. But I have another comment to make. The entire politics of elimination strategy is to, Dr. Murli was asking about the politics of it. Elimination strategies as opposed to control strategies are more central and more, they sort of spread. It's a poor way of funding, control programs, and it tends to, destroy control programs in the short run. And I would say programs like, say, illnesses like tuberculosis, or in countries where there is many provinces which have a lot of malaria also, getting a national elimination program seems a very poor way of going about things. Elimination programs tend to distribute equal funding for everyone, which is a very bad idea. Funding should be there according to the burden of the problem in an area. And the larger role of WHO and other multilateral daddies of public health, if I may say, becomes much more when you have a program like elimination than control program, because the expertise and so-called the control of data and everything is now much more centralized, rather than let it be with the provincial program manager. So I think that must be also the part of the politics of the tuberculosis program. So in short, to answer your malaria question, I think we'll be able to sequester it to fewer areas, fewer parts of the world, and within those countries, fewer provinces in those countries. But to eliminate in short run seems impossible. But compared to tuberculosis, malaria is far more eliminatable. Over.
Dr. Yogesh, we have one more question. Perhaps we'll close with that from Mr. Omar.
Thank you very much, thank you for the opportunity. I will just want to ask this question because it's very strange to me, understanding that you highlighted hunger being with a high percentage of causing tuberculosis. I just want you to dissect on that a little for a brief understanding of how that could be.
So you said undernutrition causing tuberculosis? Sorry, I didn't understand your question.
So, I said you have highlighted hunger being having the high percentage of causing tuberculosis. So I just want your clarification on that, please.
So very, very clearly, biologically, hunger or food deprivation, food inadequacy at an individual or at a family or at a community level is associated with decreased immunity. There is, in fact, this word called nutritional aids, which is nutritional related immunodeficiency that happens. This concept is there, and the same set of symptoms, same type of tuberculosis pattern that is seen in HIV patients can be seen in those who are severely undernourished and then get tuberculosis. So, but at a social and a political level, when one understands the determinants of tuberculosis disease, clearly undernutrition as I use the word hunger as an unsanitized word for malnutrition, because adult undernutrition is due to decreased food intake, not so much due to infections. So I would say less food among people to eat leads to their poor nutrition, which leads to people who have who acquire the bacteria of the TB from anywhere, from getting the infection becoming a disease. So we know in India, 40% of us have tuberculosis bacteria in our system, but only 2% of us develop the disease. And that is because those 2% are more undernourished, and they are the ones who get it into. So in India, it is 55% of people of tuberculosis that is due to hunger.
Right. Thank you very much. I think that is very clear. And then thank you for the opportunity once again.
Our pleasure, sir.
Dr. Yogesh, shall we close, or you can?
I'm fine. Yeah, I'll be. I've enjoyed every bit of this today.
Okay. So Vinod, the Mubarak.
I think there is a question from Seja. Dr. Sheza Ayas.
I think I've already read out her question, but is she there?
She has raised her hands, but no. Okay.
Okay.
Anyway, if there is no
Vinod,
question, then
Vinod, then you can thank everybody and close the session.
okay. Thank you, Professor.
So before Vinod, thank everyone. I also wish to just take this opportunity on behalf of IIT-AARDO and entire staff of the Dean's Office and Sudarshan Patnaban, all the speakers of the previous day once again, and Dr. Yogesh Jain for his insights into providing challenges in providing primary care for the marginalized. I'm very sure everyone from different contexts in living in India or in Africa would have used their own lens to draw lessons from these presentations, including today's. Thank you once again for your active participation. Every day we had nearly 80 to 100 participants today too. Thank you, Dr. Yogesh, again, once again, on behalf of all the participants and the AARDO IIT establishment. I now request Vinod to express our sincere thanks to participants and the presenters.
Thank you, Professor. I thank our speaker, Dr. Yogesh Jain, for kindly accepting our invitation and giving such a wonderful presentation. It was so informative, and we could see a very good appreciation from the audience in the chat box and WhatsApp groups as well. By seeing them, I learned that your message reached the participants well. Thank you, Dr. Yogesh, and thank you, Professor Muralidharan. We will be continuing our series of such programs in association with AARDO, and we are glad that IIT Madras is instrumental in making the fellow AARDO nations grow in the primary healthcare field. Let us grow together for a better future world. And actually, dear participants, please be informed that a feedback form will be shared, and kindly fill and revert to us. Certificates will be issued based on the attendance upon the receipt of the feedback form. Before I deliver my formal vote of thanks, I would request Dr. Sanjeev Behra to deliver the vote of thanks on behalf of AARDO. Dr. Sanjeev Behra, over to you.
Thank you very much.
Yeah.
Am I audible?
Yes, sir.
Yeah, sure. Audible.
Okay.
Go ahead.
Okay. Thank you very much. On behalf of Rural Development Organization and on behalf of our Secretary General, let me first congratulate the IIT Madras for organizing this 4-day online training program so beautifully. Needless to mention here that the program was well planned, covering both government and non-government sector in primary healthcare. Before I say something about the program, I would like to extend my sincere thanks first to Professor B.R. Muralidharan for his efforts and moderating most part of the training program. Both Professor Muralidharan and Dr. Girija Vidyanathan yesterday done a marvelous job handling the session beautifully and articulate the presentation and handling the question answer session. In fact, the chief guest, Dr. J. Radhakrishnan, Principal Secretary, Health and Family Welfare, Dr. T.S. Selvaniagam, I'm sorry for pronunciation, Director of Public Health and Prevention Medicine of Government of Tamil Nadu. They, in fact, both of them set the tone of the discussion of the training program in the inaugural function itself. AARDO is thankful to both Dr. Radhakrishnan and Dr. Selvaniagam for sparing time and addressing the participants. I am thankful to all speakers of this training program, and their valuable deliberations, and they handled the questions of the participants very beautifully. AARDO on record recognize their authority on the subjects and look forward to more collaboration in the future days to come. We are also thankful to all participants for their active participation. Here I used to tell all participants that if you need any support related to primary health care in your country, feel free to contact AARDO Secretariat through the nodal ministry of your country. And AARDO will to support to the maximum possible on its part. I am specifically responding to a query from one Mr. Tito participant. I don't know from where he is, but he has actually mentioned what will be the role of AARDO after this training program. Yes, AARDO is very much with you people. AARDO is very much with the member countries. But actually, whatever your requirement is, you please rotate through the nodal ministry, and we will make all efforts to support the maximum possible from our part. And with regard to, this is one thing. And as far as the organizing of this program is concerned, actually Professor Sudarshan Padmanabhan, he deserves a special thank. And I have no hesitation to saying that this training program was so successful, organized because of his coordination and efforts. AARDO is also thankful to Professor Raghunathan Rangaswamy, Dean of Global Environment, for all his timely support. Last but not least, the proactive role played by Mr. Binod and Madam Lisa from IIT Madras, and from my team, Mr. Kamal Dhameja, Shonam Gupta, and Dinesh Chan. Actually, you all made this program successful. I extend my sincere thanks to all of you for the required arrangements for this online training program. With these words, I once again thanks all involved in this training program, from IIT Madras, the speakers, guests, participants, and moderator. Long live African Asian solidarity. Thank you.
Thank you, Dr. Sanjeev. As we close this training program, it's my pleasure to deliver the vote of thanks on behalf of OGE, IITM, and AARDO to all who have helped make this event such a grand success. First, I would like to thank Professor V.R. Muralidharan for coordinating the program and moderating the sessions and keeping the spirit up throughout the program. Thank you, Professor. I wish to thank Professor Sudarshan Padmanabhan, anchor of Siddhi, who has always been a great support behind the program. I sincerely thank our special invitee, Dr. T.S. Selvavinayagam, Director of Public Health and Preventive Medicine, Government of Tamil Nadu, and the Chief Guest, Dr. J. Radhakrishnan, IAS, Principal Secretary to Government, Health and Family Welfare Department, Government of Tamil Nadu. I wish to thank His Excellency Dr. Manoj Nadio Singh, Secretary General, AARDO, for presiding the program. I also wish to record our sincere appreciation to the speakers. Dr. Darish Ahmed, IAS, Mission Director, Tamil Nadu National Health Mission, Chennai. Mr. Rajesh Singh, CEO, Lesh Wish, New Delhi. Dr. Rajesh Khanna, Senior Director, Programs, Lesh Wish, New Delhi. Dr. R.K. Srivastava, Senior Advisor for Innovations and Public Health, Lesh Wish, New Delhi. Dr. Amit Mishra, Consultant, Ministry of Public Health, Qatar, and today's speaker, Dr. Yogesh Jain, MD, Pediatrician, Founding Member, Jan Swasthya Sahyog, Bilaspur, Chhattisgarh, India. I further thank our moderator of the third day program, Dr. Girija Vaidyanathan, IAS, retired, former Chief Secretary, Government of Tamil Nadu. Additionally, I thank our AARDO members, Dr. Sanjeev Behra and Mr. Kamal Dhameja. At this point, I would like to extend my thanks to Professor Raghunathan Rangaswamy, Dean, Office of Global Engagement and Associate Professor, Biotechnology, IIT Madras, and Dr. Karthik Raman, our Advisor, Conference Secretary Team. Thanks are also due to Mr. Sairam, Ms. Narayani, and Ms. Rashmi from our media cell for the excellent coverage of the program. Finally, I thank my own teammates, Ms. Lisa Eril, Mr. Srivaram, and Mr. Rudramurthy, who has helped tremendously throughout the program. Above all, I thank all the participants from various countries, as your participation has made this training program a successful event. Thank you, one and all. I request everyone to stay connected. Thank you once again for joining.
Thank you, everyone, and thank you, Dr. Yogesh. We'll keep in touch.
Absolutely, sir.
Any member country through their ministry, when they approach our side, we would look forward to your expertise and experience in rural, tribal, Adivasi areas too, among others. Thank you very much once again.
So thank you, sir. Thank you very much for the great program. And I am from Hyderabad, NIMSME. It is National Institute for Micro, Small and Medium Enterprises.
Thank you.
Special thanks to IIT Madras and AARDO for giving us an option. Thank you very much.
Thank you. Okay, Yogesh. I'm yet to visit your place. Soon I will plan.
Yeah, thank you.
Please, sir. Whenever. All right, sir. Bye.
Okay, Vinod, we'll close.
Thank you, Professor. Dear participants, gentle reminder for submitting your feedback form. It will be sent to your mail. Okay.
So feedback form will be, you will be
Yeah,
sending
it
to
will be
mail or
mailed you.
mail, sir?
Yeah.
Thank you. Thank you. Thank you.
Thank you. Thank you.